Time to, hi, Leah, I didn't take you off. Hi, this is Deirdre Vervo. Welcome to
We can't hear you.
Are you hearing me? Okay. Hi, this is Deirdre Vervo. Welcome to Let's Talk. There's memory care issues, Alzheimer's, dementia, and Parkinson's. Today, I have very special guests on from hospice. They're going to talk about hospice. They're from Caring Hospice Services. And there's so many misconceptions about hospice. I myself didn't know anything about it. About 5 years ago. My own dad passed, and I was investigating services. I wasn't sure if it was just end of life, if it was when you brought your loved one home, there was no other hope, or was it to keep them from being in pain? I had no idea. So I think a lot of people also don't know it's not one big company. So I'm going to bring on today from community lady, Janelle Minar, as well as Candy Baker, and she's a patient care manager and clinical supervisor, and they're both with Caring Hospice Services. So without further ado, ladies, can you hear me?
Yes,
I can hear you now.
Super. Thank you so much for joining. So welcome Janelle and Candy. And I know we met today. But why don't you give us a little bit of your background, Candy? Like, how did you start in this? Did you what's your background and how did you decide to be in hospice? Because really, quite an emotional person.
Well, to be quite honest, hospice found me, a recruiter found me, and I went for an interview and got the job. So when I started with my first program, first agency, I was green and I had to learn. So I just fell into it. I like
So were you a nurse before? What was your background?
Nurse. I've been in psychiatric nursing. I've been in, ICUs. I've been a nurse for over 30 years. So I've had many things. I have my BSN. I have a master's in public health administration, and that's helped me on my journey, needless to say, but that's my background. But I've been working in hospice for 6 years now, and I love it.
Wow. And so do you find it tough to work with seniors that are
it feels my need to help. So I actually feel good about it. It's hard to play in our shoes. Our goals.
Wow. And Janelle, how did you come about doing hospice, or did they find you out?
Well, dear, I actually have been, and I always like to preface whatever I say with the fact that I'm not a nurse, but I do feel very blessed to work with a fine group of clinicians, nurses, social workers, interfaith chaplains, certified nursing assistants, and our medical director position. And actually, I grew up with hospice because my mom is a nurse. And as a little girl, even though there was a period of time she wasn't working full time, she would get called to different people's homes who needed hospice care, home care hospice. And many times I accompanied her on those visits and would make my way. I spent many times at people's kitchen or dining room tables doing my homework, waiting there for my dad to pick me up on his way home from work. And I have to say that I didn't realize just how valuable that was, those times spent with families that not only were experiencing hardship and pain, but also the celebration of life. And really, there was a lot of gathering. There was a lot of really celebrating life and offering kindness. And it was very powerful to see the difference that my mom made in the lives of many of those families. And so I grew up learning about life while being with people who were journeying towards the end of their lives. And really until I was an adult that I understood just how special that was, and then it did end up that one thing led to another, which led me to an opportunity to use my personal experience, my lifetime of personal experience, in what I do every day, which is really, really special to me because I love people, I love life, and I love being a part of helping people with the quality of their life, which is really what hospice is all about. It's a whole lot more about life and quality of life than not. And we really want to get the word out there to help people not be afraid to talk about it.
So you have a very empathetic family, and your mother must be so proud now that you kind of followed in her footsteps. You can make your sound louder.
I'm so sorry we weren't hear what you were saying.
Make your sound a little louder if you can't hear me this live. So can you make the sound on yours, your volume?
The sound is loud. It's just that it was garbled.
Oh, sorry. So sorry about that. We'll try our best to. Can you hear me now? Can you hear me now?
Yes.
Okay. So it sounds like you grew up in a very empathetic household. Your mother must be so proud that basically followed in her footsteps from seeing her own works and deeds. So tell me what kind of things hospice does. And this year more than ever, it's so needed because of the pandemic and everybody's shut in. And you guys are just a godsend to go where families can't be right now. So how is it? To first tell what Caring Hospice Services has to offer, and when people like call you, what should they know hospice?
Well, we're referred usually by their doctors or another family member or a friend, and most people have a very small understanding of hospice when they start with us, unless they've had a family member in hospice prior. But the most important thing about hospice is we want to keep people comfortable and safe. And if somebody has a disease where there can't be a cure and they're getting, a little bit closer towards being able to function properly, it's a perfect time for us to come in. We have home health aides that can help the patient. The nurses come, and depending on how ill they are at the time, they come anywhere from 1 to 3 times a week. Depending on what's going on. If they have wound care, it's often 3 times a week just to begin with wound care. So it varies, but we're there to help the patient and the families. The families are a big part of hospice also. It's usually the children or family member who's really speaking for the patient. A lot of our patients help.
So now, is hospice care just at home, or do you go into facilities, or where?
All of them.
Okay.
We have patients who are in their home, and we provide care for them at home. We have patients who are in ALFs and in skilled nursing facilities, and we go in and provide care for them there. And some facilities have inpatient. There's such a thing as inpatient, where the nurses are around.
So we bring the care to the patient wherever home is for that patient. And like Candy said, in some cases it is their private home. Other times the assisted living community is their home. So we're visiting them in their home. And the visits, because today we're talking about routine level hospice care, which is the most common of all the levels. And the visits are intermittent, meaning that unless the person does have a reason for having multiple, like 2 or 3 times a week scheduled visits, it's usually weekly visits. The RN case manager comes in to visit weekly, as well as the certified nursing assistant or home health aide would be in a couple of times, 2 to 3 times a week, for assist with some of the parts of plan of care for that person. And then we also have a social worker and interfaith chaplain who can be involved. They're not as involved, their visits aren't as frequent as the nursing visits, but they are also involved in person as well as over the phone. And in between those visits, Deidre, what I'd like people to know is we have a 24-hour number. So we would never want a patient to wait. Like if something happens, either they have a question or if they have a change of condition, we wouldn't want the person taking care of them to wait until that next nursing visit before giving us a call. We say, give us a call and we can find out, is this something that needs to be addressed right now? And if so, we do have nurses that would go out after hours. Sometimes it doesn't require a visit. Sometimes it's something that can be addressed over the phone, or it just may be a question that needs to be answered. But what I love about Caring Hospice is when you call that number, you get a person. If our office is open, which is Monday through Friday from 8:30 a.m. to 5 p.m., you'll get someone in our office. Candy may be answering the phone, or it could be our program director or our office coordinator or volunteer coordinator, or any of the many staff members who may be there at the time. But when the office is not open, we have an answering service with a live person that answers the phone. So there's no answering machine or buttons to push. You're going to get a human being.
And we have nursing available 24/7. So we have an evening nurse and a night nurse. So there's coverage 24/7 if somebody really needs help in the middle of the night too. They're having a lot of pain or having.
How did you know when to call? Let's say I had my grandparent with me or my parent, and how would I know when to call you? How would they be in a lot of pain? Would there be, what is the signs? Like when would we call hospice in? When the doctor says like there's no hope here, we want to make them comfortable. We don't want to keep doing anything else, or you opt out of extraordinary measures. When call you?
There's multiple ways. It's either the doctor suggesting, there's nothing we can do to cure you, and he feels that the patient has somewhere around 6 months to live. That's really, on paper, it's supposed to be 6 months to live, but we have people who do go beyond that, and when people graduate, where we discharge them. But so we get doctor refer patient to us, or a family member, they're failing, they're not doing well. The patient said, who's not a patient yet, I don't want to go to the hospital, or I'm sick of going to the hospital, I don't want any more treatment. They have a disease that could end their life, the diagnosis, then they're eligible. So it can come from a family member, from a doctor, patient themselves, can come from a friend. But hospice touches your heart once you've had hospice. So if a sister's had somebody they know who's had hospice, they'll end up with something. So, somebody will come up with the idea because the patient doesn't want treatment anymore. And that's one of the basics of hospice eligibility, is not wanting treatment anymore.
That's so then you go in now, and hospice is also covered by Medicare.
Yep, totally.
Entirely covered.
It's a free service. So do they have to have a referral from their doctor?
No, it's hospice is a Medicare benefit. So everybody who has a Medicare or a Advantage program where it has, they have Medigap or United Health, Meta something, they're also use their Medicare benefit, and it's free. And our services, for the most part, are, it has to be related to their diagnosis, and the other diagnoses that are related to why they're not getting treatment anymore. So if somebody, for example, has an eye infection, we won't necessarily cover that, but somebody will get treatment for them and help for them, depending.
And hospice can be also deliver durable goods, right?
Yeah, we supply all those. We'll supply a hospital bed, a bedside commode, an over the table, a special mattress so that they don't have skin breakdown. So yeah, we have all sorts of things to make their lives more comfortable.
That's wonderful.
Yeah.
I don't realize that. I don't know if people realize that.
Deirdre, so many people don't realize it, and unfortunately, just the word hospice can sometimes be a barrier to getting them the information that could be so valuable to them. or to a family member or a friend.
Mhm.
And so we ask ourselves a lot of times, if hospice is all about comfort, then why is it so uncomfortable to talk about? And that's the reality that we are really trying to break down and break through to make it comfortable for people to learn about it early, because the sooner you learn about it and the more you're aware of it, the less it seems to be scary.
Yeah.
And it's really an option. It's a healthcare option that people should be, of which people should be aware, that is entirely covered by Medicare. And whether someone ever uses it or not, it's really, really good for them to be informed. So whatever decision they do make about their healthcare, they're making it in the most informed way possible, to knowing all their options. And when we get calls for people to learn about hospice, we do a lot of hospice education in the community and with families that call us. And when we get those calls, we're not there to convince anyone of hospice or tell them that they should do it. We're there to make sure they have the information and empower them to make the decision that's best for their family.
An educated decision.
Yeah. And it's a personal decision. It's a choice. And so is the agency a choice. And that's important too, that the families know that they have choices.
Right. So hospice is not one big agency. It's many private agencies. So we're Caring Hospice Services cover.
We missed what you said.
Yeah.
Where does Caring Hospice Services cover? Do you cover Fairfield County?
Oh, the area that we cover. So for Caring Hospice Services of Connecticut, we cover the shoreline towns of Fairfield County, from Greenwich all the way up. Actually, we go through Stratford to the southern tip of New Haven County, because we also cover Milford. And we triangle up into the Ridgefield, Wilton area.
Mhm.
But our agency also has locations in New Jersey, Pennsylvania, New York, Ohio, and most recently, Massachusetts.
Yeah.
So recently, we were going to call in hospice for my mother-in-law for palliative care. Can you talk about what difference is between palliative care and hospice care, or the same?
I can't.
The difference between palliative and hospice.
Oh, good question. Palliative care is for someone who still wants to seek treatment, but they want comfort measures. You know, they don't want necessarily anything hugely done for them, but they may want to be a do not resuscitate, or they may still want to seek treatment for whatever illness they have. Once you go to hospice, you have to agree to not have it treated anymore, because the purpose of it is to make you as comfortable as possible for the rest of your life, however long that they'll be. But our patients do not decide to make this decision. They're sick and tired of the treatment. They just don't want it anymore, or they know it's not going to do anything for them anymore.
So go on palliative care. What type, like somebody with cancer, or when we call in and that?
Well, that's very different. We don't take palliative patients. Maybe a palliative patient could go to a regular home care facility, and that would probably be more appropriate, because if they still want to get treatment, they'll be able to give that. And some people just do it from home. I mean, their family members help them, and they don't go to any agency. They just help take care of them at home with the help of the doctor. But there's
Just giving pain medication. Then what is palliative care? Is that just at-home pain medication?
That's part, that would be part with hospice. With regard to hospice, I'm sorry, you got cut out a little bit. So with regard to hospice, yes, that does include pain medication. It's just part of it. Hospice is the whole philosophy. So you have an interdisciplinary team with a lot of people involved. With palliative care, yes, it does include pain management,
it's a big part of
comfort
what we do.
measures,
Yeah.
but it's not as comprehensive as hospice.
Yeah, you can't compare the two.
So how would somebody know that they are eligible for hospice? What is eligibility? What requirements?
Well, for a lay person, that would be hard to say. What we do is we go through their medical records. We may have to make sure that they have a diagnosis and supporting evidence that they are going to meet the requirements of Medicare for hospice benefit. And that's certain illnesses and diseases. And we have to have supporting evidence that things may be starting to fade. Maybe they're not eating as much, or they're sleeping too much. They may be a little short of breath. There's all sorts of things that you see a family member that you're close to, or a friend that you're close to. You see when they start declining. Mm-hmm. So, we get patients, we get referrals. Sometimes they're not eligible yet, but we touch base, we'll do an evaluation. And when they're really are eligible, they'll come back and come on our service. It's something a layperson can't really tell. I mean, if it's your parent, you're going to see that they're declining and that they really can't take care of themselves alone. Let's say they can't walk on their own, or things like that. And they'll reach out to the patient's doctor and they can discuss it. Or some people just call us directly to ask kind of questions you're asking us.
Have you ever had people that you turned down? Not because they were ineligible, but you felt like you kind of had to talk them out of it, like maybe they're young and cancer and they just didn't want to go through treatment, or?
This is a person's decision. We can't try to talk anybody out of anything because that's not our job. Our job is to help them with what they desire. So the only reason to turn down somebody if they're in a very unsafe environment and they're not willing to do anything to make it safer. That's about the only reason, other than they're not eligible medically, why we would turn somebody down. In that case, we'd ask them to hire somebody to stay with them. It's like somebody who's older and debilitated and is on a trajectory towards the end of their life, and they have nobody to help them. They're alone in this condo or apartment or wherever, all alone, having to walk upstairs. I mean, this is all things that are very unsafe. If they're unwilling to do things to change these things and make it safer for them, we won't take it. And this is the rules are the same for all agencies. This is Medicare. It has regulations and rules that we have to follow.
So
we would get.
Go ahead.
No, I was just going to say we would make sure that we put them in touch with resources that could help them be safe, even if it weren't with hospice.
Right.
Okay. And I want you to be clear, you take people Medicaid and Medicare, their benefits of both.
Yes.
What about if you're not older? Is it a benefit of your insurance company if you're younger and you're not on Medicare, Medicaid?
Each individual, they would have to really find out what their insurance, if it's private insurance, what they have. Most of them do have what's called per diem, which is the same thing as hospice, component of it. But that's somebody, when you purchase your health insurance, you have to know. We've had people as young as 20, so it's not age, it's, what's going on with themselves. So you get young people with cancer, and then they can't do anything about it. So it has nothing to do with age. And I know young people with Medicare, because once they're debilitated, whoever they go to for help may apply for them to make it easier for them.
Oh, okay. So if the nurses are not coming, if it's intermittent care, who's caring for them in between? Are the family members?
So the Medicare hospice benefit does not cover custodial care. And so, yes, the family is either directly responsible, or in a private home, they may hire private help, which would be privately paid by the family. There are people that have long-term care insurance, and that helps. Again, it's still private pay, but that they use that. Other people are in assisted living communities, and they have different levels of care that they work out with the living community where the person resides, and they take responsibility for much of the custodial care. And then, of course, there's also skilled nursing facilities or long-term care facilities where the custodial care would be provided. And sometimes it's a combination. Sometimes they have to supplement based on what the family can do, based on what the assisted living can do, and then they put that together. But teen level care hospice benefit does not cover custodial care. And we're glad you brought that up, Deirdre, too, because we also, when we meet with families, we like to talk about the benefit, all of the people involved in the care, We talked about like the durable medical equipment, such as the hospital bed and wheelchair. We didn't mention, but also included would be supplies such as incontinence supplies, disposable underwear, bed protectors, gloves, wipes, all of those things. But we like the families to know what hospice does not cover and what hospice is not about. So we all start off on the same page with good sound expectations, so that the patient can be the focus on our care, and we all know what each other is doing, and the part that we take in the care of that patient.
So I think that's a godsend because it's so expensive. Like gloves and the pens and the equipment and everything. That really, especially if you're caring for somebody and you've quit your job or you're staying home, not just at a emotional toll, physical toll, but now financial toll. So that's really amazing. Now, what kind of things to explain that hospice not do? What do you?
I want to say one thing though. A lot of agencies do not provide briefs, pull-ups, and diapers. We do, which is I think rather unusual. So it would be a question for the family to ask what's provided for, because the previous agency I worked for did not supply anything like that. I think it's amazing.
Those are pricey.
What's that?
Those can be quite costly.
Yes.
Mm-hmm.
Yes. I think it's wonderful we do provide them, because often not.
Yeah. So it's one of the big misconceptions about hospice.
Yeah.
You run into all the time.
Yeah. It depends on your agency with that kind of stuff. I mean, during the height of COVID, we were supplying masks and cover-ups and everything for the patients' families too. I mean, that's remarkable. I can promise you very few agencies would do that. But we would keep our patient and the family safe too.
Yeah. So we just had a woman at our home on hospice. She was almost 99. And the daughter was administering the morphine.
Yeah. We teach the family members.
Yeah. I didn't know that's how I figured the nurse came in and did that. But I guess since it was every hours, they teach the family members. So a nurse have to come in every 4 hours. Is that typical of what happens?
Yes. It's a team effort. The families are part of the team to take care of their loved one. So it's absolutely, it's very common. We immediately, sometimes it's at admission and sometimes it may be a day later, but we teach the family about the medication, how to give them and when to give them. And of course, if you're doing your visit and they're having symptoms, we will take care of them at that time. But if we had to go in and give a medication to every single patient whenever they needed something, we'd need a million nurses to go around. It's not feasible. So it is a team effort with the family or the loved ones.
And in a different environment, if it were in a traditional assisted living community or a long-term care facility, then there's usually medication administration in place where the family doesn't have to be involved in that. But in a private home setting, the families are typically involved, like Candy was saying.
Well, I think too that, like you were saying, hearing the word hospice makes people a little nervous, like that they're going to die. But I think what a beautiful thing is typically when you're home and you're that sick, you've already had visiting nurse service. You've already had many people in your home. So you could be like this is another visiting nurse, because the hospice people look like visiting nurse. They're coming in. You don't actually have to say hospice. Do you have a lot of people say, please don't say hospice?
Yes. Quite often.
Just say you're a visiting, say you're a nurse visiting.
Nurse, yeah. We honor their wishes. So if, they don't want us to mention it to their family member, we're not going to say anything. Eventually they're going to figure it out because, everywhere there's a badge. And with time, they usually find out, but not from us.
We're very sensitive to it. It is the patient's right to know the care that person is receiving. But we are very, very sensitive to it. And so we just need to, we always, if we could flip a switch and not mention the word, we would, but that's not possible. It's even part of our name, Caring Hospice Services. And so, but it's a good conversation to have with the family. We like to talk about everything that may be of concern to the family ahead of time. And of course, we won't always think of everything ahead of time. So, or what the family's concerns are is what I'm saying. And so we encourage the families, give us a call. If something comes up that you haven't thought of, give us a call. Or if you've changed the way you feel about it. The other good thing to know is that there's nothing binding about the hospice consents or a contract with hospice. So it's the patient's right, or the family member who's making the decision. It's his or her right to change their mind at any time. They can change the kind of care they want to receive. And so if for some reason they wanted to start curative measures or just not have hospice, they don't have to have any reason other than they don't want hospice anymore, and they can revoke the services. So it's important they know they have their rights, and that they're in control of the care that they're receiving. Because that's part of the comfort measures as far as I'm concerned as well. Just having that peace of mind.
So you're saying like they could be like, I changed my mind, I want extraordinary measures. And then they could go to hospital?
We can't hear you.
Are you saying that they can change their mind and say like, I decided I want extraordinary measures, I'm changing my mind? Okay. Well, what I think is one of the most beautiful parts about what you do is the comfort you bring to the families. It's, the patient, the person who's ill, that's one thing, but the families are in such, they're just so, it's just a whirlwind going on with them. That's what I see. And they don't know what to do. They've never experienced it. And the comfort and the level of you being there 24 hours a day to answer any question and be on call. It's a nerve-wracking experience when you have somebody that's 90 years old in the middle of the night gasping for air. So just you being there to comfort the family, to let the family know what to do. That's so important. And to let the family know what to expect, the person's declining. And to let the family members know what's typical, what's standard, what's going to happen next. I think that's brought so much comfort to the families that I've seen using hospice. I think it's almost more comfort for the families.
Yeah.
The patient is great. They're going out of this, which is beautiful. But for the families, also doing such giant service for them to know what's going on and to know they've done everything they could, and to know that you're there. And it's a loving thing. It's such a loving thing.
Yeah, we end up usually being very close to the families and often the patients. I mean, because it's even though it doesn't sound long term, it's often a long term relationship you have, and you get very close, and the families share their feelings with you. So a lot of times, most times, all of us, including me, doesn't do direct patient care. Typically, end up being close to the family member. Very special. It really is.
It really is very special, and people respond in ways, and we are faced with a lot of unexpected surprises. Deidre, I will tell you that sometimes I can't say necessarily what it is, but maybe it's less stress, less pressure about getting better, and all of a sudden they get to hospice and they're rallying. They seem to be improving. And these are situations where eventually, if the person either continues to improve or does not continue to decline, we have to discuss discharging that patient from our services with the family and graduating from hospice. And it's sometimes the people who were most reluctant about coming on to hospice or waited are the ones that are like, oh no, please don't go, because we have such a nice rapport with them, and they bring their faith into it if they want. That's totally a choice, of course, and we extend the interfaith chaplain services and the spiritual services. They can certainly decline it if they want, but many people do bring that in, And it's a whole other layer of connection that it offers for our team and the family to share. But it's also important for people to know that if they were to be discharged from our services or graduate, like I said, or if they ever decided to revoke hospice, that the benefit remains available to them the rest of their lives. So it is a lifetime benefit under Medicare. That doesn't mean once you're on it, you always are eligible for it and continuously receive it. But what it means is if you are eligible for it, you can access it.
And so, more than once.
Yeah, multiple times.
Yeah.
As a matter of fact, there have been, many times we have people coming onto our services that have already been on hospice in the past. But there was one particular time we remember that the person had forgotten that she was ever on hospice because it had been 11 years prior to getting referred to us. And I guess it was just a very, very difficult time in her life. She went through a physical crisis and decline, but ended up doing very well, getting off hospice.
That is a beautiful thing.
Yeah,
somebody wants
the doctor saying this patient only has a few weeks to live, and they'll be on forever with us. Once in a while, so it's interesting. Sometimes when they get that care and they feel like really in there for them, supporting them, they sometimes wrap. It's just amazing some of the things we see. I mean, that's not always, it does happen.
There's a very, very powerful connection between kindness and competence. When you have both together, it's beautiful. Yeah. It's really, really beautiful. And we have each of us brings to the team a very special story as to why we're here, and families feel it.
Well, I could tell you're both very kind people. You're both very competent people, and being there for the end of a family's life is so intimate. No wonder you bond so readily with them. It's just you're being brought in at such an intimate time of life. It's kind of like being there when somebody's giving birth, being there when they're passing. So it's it's great and it's amazing. So, ladies, it's been a pleasure. If somebody wants to get in touch with you, let me put the number on screen. Caring Hospice Services 203-674-8380. Is the best thing. If they want to learn more about hospice, can they just call?
Yes, certainly. We would welcome that. We would welcome that, and we hope you do, because we learn from hearing from you just as much as we have to offer. And if you call with a question that we don't have the answer to, we do what we can to try to put you in touch with someone who may be able to help you. And we love helping people.
Yeah.
Well, Candy, Janelle, you two are just lovely people. And I've been having you on the show, and I'm sure everybody to hear all about hospice and how caring hospices can help. And I look forward to seeing you in the chair soon. But very beautiful thing you're doing. Very,
thank you, Deirdre, and thank you for having us.
Thank you so much for coming on. Love to both of you.
You too.
Take care.
Bye for now. Wow. I didn't know much about hospice, and just recently I've had 2 experiences in hospice, and they were both beautiful. The hospice were like angels. They come in, they're loving, they're caring, they're respectful. They really help the families understand what end of life measures are, what's happening to their loved one and why. And it's more of a comfort to the family, I think than making the patient comfortable when they're passing is great. But the family just so concerned and so upset, so confused, so worried that they're not doing everything possible. And these angels come in and share with them that you're doing everything right. This is just beautiful, and keep it up. And we're here to support you. Just great. So I just had nothing. It's been a beautiful thing watching people pass with hospice. It's just been a beautiful thing, and I've been so happy to be part of it. So, well, I hope if you need hospice, I hope you don't need hospice soon, but I hope if you do, remember our beautiful Candy and Janelle and the great people at Caring Hospice. So thank you so much for tuning in. Until tomorrow. Until next week. Take care.
Hi, Deirdre here again. Thank you for joining me on Let's Talk Seniors Memory Care Issues. Is this an issue hitting home? Do you have a parent or loved one with memory care issues who you feel is not safe at home anymore? Are isolation, falls, and safety issues becoming a big concern? Welcome to Dogwood Senior Home, premier boutique residential senior living specializing in memory care. It's country living at its best in the Huntington section of Shelton, Connecticut. We're truly a home with only 6 senior residents living as one family unit. Senior residential homes are concepts sweeping the nation with 47,000 across the U.S. We're pleased to open Dogwood Senior Home as it will be only number 6 for Connecticut. Brand new, sparkling clean, opening mid-June. And safe. We are COVID-free. Residential care homes boast a very low COVID infection rate across the nation. This is due to the intimacy of size and speed in which the caretakers can shift to accommodate immediate needs. They are much safer than the large homes and facilities, as you can imagine. It has been documented that residents have less falls and a better quality of life in a residential home environment. Our home is more affordable than the big box facility. You pay one all-inclusive price, and that price is guaranteed for the life of the resident. With an incredible 1-to-3 caregiver ratio, which you won't find anywhere else. Our friendly, loving caregivers are dedicated and trained in Alzheimer's, dementia, and Parkinson's issues. We're only taking 6 residents, so the home will fill up fast. Call me at 203-689-7562 for a talk and tour. I would love to meet you and your loved one. See you soon. Bye.